Hello and welcome to our section 3 video on breathing. Our learning objectives here are going to be to describe how the structures of the lungs and thoracic cavity control the mechanics of breathing, explain the importance of compliance and resistance in the lungs, and discuss problems that may arise due to a VQ mismatch. So we'll start off with the mechanics of human breathing. We need to understand Boyle's gas law, which essentially describes the relationship between volume and pressure. When we have a constant temperature, we're going to see that the pressure of a gas is going to decrease as the volume of the container increases. So I think this is first best illustrated in this image down here, where we can see we have increased volume here. And so the pressure is going to be decreased. We can see the molecules are pretty widespread here and they're not going to make as much contact with one another. But as we push this piston down and we have a decreased volume, we're going to have increased pressure and these molecules are going to come more into contact with one another. We can also see this demonstrated in the figure from your book, where we have increased pressure means that we have low volume, but then as we continue to increase the volume, the pressure decreases. So they really have this inverse relationship with one another. And so ventilation is going to be governed by that same law. Here we have an image of a alveolus, and we can see as we inhale, that volume is going to increase of the alveoli, and the pressure in here is going to decrease. When we exhale, the volume is going to decrease, which means the air pressure in the alveolus is going to increase. So we've talked about ventilation in section 1, and this is going to take place in 2 phases. We have inspiration, in which we're bringing that air into our lungs, and expiration or exhalation, where we move that air out of our lungs. So remember that it is just the air moving in and out of our lungs. There's no gas exchange taking place when we talk about ventilation. The term we use for gas exchange is respiration. And so let's start talking about what is moving in order to get this air in and out of our lungs. We know that our rib cage is going to surround our thoracic cavity by the top sides and of course the lateral sides. And in between these ribs that make up our rib cage are going to be these intercostal muscles. Inter means between, costo means rib. So in between these ribs are the muscles, and we're going to see them contract in different ways to make our thoracic cavity larger or smaller. And our lungs are going to adhere to our thoracic wall through the pleura. We've talked about pleura before, and if you remember, we have 2 layers, a parietal and visceral, and in between there gets a space created, and that space is called our pleural space or pleural cavity that would be filled with the pleural fluid. We're going to talk more about that in a little bit. But here are our external intercostal muscles. We'll see these more on the lateral aspect of the rib cage, and they're used during inspiration. Whereas here we have our internal intercostal muscles, and we'll find more of these closer to what we call the medial aspect of the rib cage. So I know they still kind of look a little bit lateral here. But when we see these in the lab, you'll see that they're better defined more anteriorly here, closer to the sternum. And they are used during expiration. So let's go through each of these phases and talk about what happens. Inspiration, when we breathe the air in, is known as our active phase of ventilation. And our diaphragm is going to contract and become flattened. And I want you to think of this as the muscle fibers shortening, right? They're all pulling into one another, and that helps to bring the diaphragm down. The other muscles that are going to help us are our external intercostal muscles. So you could see them over here, and they're going to cause our rib cage to move upward and outward. So almost like a handle on a bucket, it's going to lift up. And these actions help to increase our thoracic cage size. And so this becomes kind of like a dance between our lungs and our thoracic cavity. They both have to increase in size at the same time. If our lungs were increasing while our rib cage stayed put, we wouldn't be able to inflate the lungs as much as we can, right? So our lung volume increases, and we know due to Boyle's law, the air pressure in the alveoli are going to decrease. So our alveolar pressure is now less than the atmospheric pressure, and air is going to flow from the outside of our body to the inside of our lungs, into the alveoli as it's moving in. Next, let's talk about expiration, which is known as the passive phase of breathing. Now those muscles that were contracted in inspiration are going to relax. So the diaphragm relaxes and turns into this dome shape, and our external intercostal muscles are also relaxing. This helps bring the rib cage back to its resting position, meaning that these ribs are going to be set down, kind of like a handle on a bucket, like we said. It's just going to go down instead of up, and then the sternum is going to move inward. So think that it moves closer to the center of your thoracic cavity. And as we're doing that, the lungs are going to recoil. So think of kind of like a rubber band type of situation when you had stretched it out and you're letting it kind of go back to its original shape. And the air pressure is now going to increase because we are reducing the amount of air volume within the lungs, and this causes air to flow out. Now, we haven't discussed surfactant too much just yet, but that substance is inside the alveoli and it prevents them from collapsing during expiration. We also have the assistance of the lungs being able to recoil, and the pressure between our two pleura, the visceral pleura and the parietal pleura, that is going to decrease. And this helps to keep the alveoli nice and open. However, when we get into a car accident or any accident that is going to cause a puncture within the thoracic cavity, the air from the atmosphere is going to enter the space between the two pleura. So out here we would have our parietal pleura, and this would be our visceral pleura against the lung. And as that pressure starts to increase because of that air entering in, it pushes onto the lung and the lung begins to collapse. Now, those were some just normal breathing mechanisms that we talked about, but what happens when we breathe hard? This means we have maximum inspiratory effort and we're using extra muscles, what we call accessory muscles of the back, chest, and the neck. We'll see an increase in size of the thoracic cavity more than usual, and it'll allow for maximum expansion of the lungs. So let's talk about our expiration being forced, such as when we're singing or blowing air. Think like when you're blowing a balloon up, and we're going to get contraction of those internal intercostal muscles now. Remember that we find them in between the ribs, and then our external intercostal muscles are going to relax. But with our internal intercostal muscles, they are helping to kind of pull that rib down into the thoracic cavity, so it kind of pushes on the lungs a bit more to really push all the air out. And when we want our abdominal muscles to contract, they push on our abdominal organs in here and can help push against the diaphragm to create more of that dome shape, which helps to force the air out. Now, we keep talking about the pleura. I know we talked about this before, but just wanted to review to make sure we're all on the same page. Pleura are set up as a double serous membrane, and we are going to see two layers. We have the visceral layer that we just said was on the lung itself, and then we have the parietal pleura that is going to line our thoracic cavity. And each lung is enclosed in a separate visceral pleura membrane, and this really helps to limit the spread of infections. So they're not connected as far as their visceral pleura. And then that creates a pleural cavity, so this space between the parietal and visceral pleura. And when our lungs are inflated, that space becomes much smaller. So it's almost more considered of a potential space. Still within this area, we're going to have that serous fluid, which helps to lubricate this area so that pleura can slide easily against one another as we're breathing, and the lungs are inflating and deflating. Now, if that pleural fluid is not there, that serous fluid, then we could develop something called pleurisy, which is when these two layers, the visceral pleura and parietal pleura, are rubbing against one another and creating friction. It causes inflammation of those pleural membranes, and we can have severe chest pain with breathing, and we tend to see this only affected on one side of the thorax. Now let's get into some of the specific pressures we have in or around the lungs. So in that pleural cavity, we are going to have an intrapleural pressure between those membranes, and we talked about how that is low. Now our chest wall is configured so that we can expand outward when we inhale, and our lungs are going to cling to the chest wall due to our serous fluid's surface tension. We'll talk more about surface tension on the next slide, so put a pin on that. But our elastic tissue is kind of fighting that and wants to pull the lung inward. So what happens overall is that because our intrapulmonary pressure, or the pressure inside our alveoli, is greater than the intrapleural pressure here, the lungs remain inflated. This is because our intrapleural pressure is always slightly negative. So it creates kind of a suction effect that is going to pull the lungs outward and keeps them inflated against the chest wall, even when we exhale, especially because of that residual volume that we have within our lungs. All right, now let's talk in more detail about surfactant. So our pleural fluid has surface tension, which adheres the parietal and visceral pleura, but it lubricates it as well. And so with that, we're going to create some surface tension due to the hydrogen bonds between water molecules. We talked about this early on in the semester. You can see how this droplet of water is pulling and creating walls in itself, right? And so it's because of that surface tension that when our thoracic cavity enlarges, the parietal pleura is going to pull the visceral pleura and therefore the lungs outward, and we get an increase in the size of the lungs like we see here. And oxygen is going to diffuse across our alveolar wall. So I like this figure over here that kind of shows our blood capillary, and here's the wall of our alveolus. So we've got air on this side, blood on this side. And so as we start to build up the oxygen here in our alveolus, it is going to want to cross and go over into our blood. And carbon dioxide is building up in our blood here, or already built up, I should say, and that is going to want to move into our alveolus. And our alveoli is lined with that surfactant. So this is showing us all of our different alveoli here, and we've got these little cells here that are producing the surfactant. Surfactant is a lipoprotein that lowers surface tension of water. So while we have that surface tension between the pleura, we don't really want it to exist here in the alveoli. If we didn't have surfactant, then the water that exists within our alveolus would be attracted to one another, and it would pull the alveolus in, essentially causing it to kind of collapse. Whereas here, the surfactant helps to spread out those water molecules so that they're not as attracted to one another and keeps the alveolus nice and open. Unfortunately, there's a condition called infant respiratory distress syndrome, in which premature infants don't make enough of surfactant and the alveoli can collapse. So the solution to this is to just give them artificial surfactant until their body starts to produce it on their own. The next major topic we are going to discuss is lung resistance and compliance. So with our airflow, we want to think of the amount of air moving in and out of the lungs with each breath. And this depends on two major things: the pressure gradient that we are establishing between the atmosphere and our intrapulmonary pressure, so the pressure within our alveoli, and the resistance that's going to occur when we have conditions within our airways, our lungs, and chest wall. So we're going to talk more about this piece in the coming slides when it comes to certain diseases. And if they cause resistance to increase, then that airflow is going to lessen for us. So resistance are factors that increase the difficulty of moving air. This could take place due to a change in elasticity of our chest wall, and ways this can take place is just with aging and certain diseases. Sometimes we have vertebral malformations, which can also increase as we age, such as scoliosis, sometimes arthritis within the thoracic cavity, or some of our elastic tissue can be replaced by scar tissue known as pulmonary fibrosis. So I'll bring that term up again in a bit. The other thing that can alter and increase resistance is a change in bronchial diameter, or referred to as the size in our airway passages. So if you remember in section 1, we talked about how in our lungs we change from our bronchi into smaller tubes called bronchioles. And so we can go through something called bronchoconstriction or even occlusion, which would increase the resistance of the air here. This constriction could be caused by our parasympathetic activity, when we have a release of histamine, such as within certain allergies. For instance, my son, in a few months ago, he has an allergy to tree nuts, and he had tried a sample of ice cream and it happened to have walnuts in it, and he started to experience this bronchoconstriction because his body started releasing all this excess histamine. Sometimes people also will have this happen when they are exposed to the cold, and we can start to secrete excess mucus and inflammation can take place, causing a bronchoconstriction. Or if we think of the opposite of our parasympathetic nervous system, if we have sympathetic stimulation that decreases, then it can lead to bronchoconstriction, just because we're kind of withdrawing that sympathetic nervous stimulation that should cause bronchodilation. So if that seemed a little confusing, what I'm trying to say is sympathetic nervous system causes bronchodilation and parasympathetic nervous system causes bronchoconstriction. And so if we are muting the sympathetic nervous system, it may lead to bronchoconstriction. That's not to say that when we are resting and digesting that our bronchi or bronchioles are constricted, but it can increase its activity, causing bronchoconstriction in certain situations. Lastly, we have the collapse of alveoli. This can take place if those type 2 alveolar cells are not producing enough surfactant. So if you remember this image over here, this is kind of what's happening when we lose the functionality of surfactant, which we know is going to then create a high surface tension of our alveoli that we cannot overcome. This is, again, an important factor for our premature infants that aren't able to produce surfactant. And we tend to see these alveoli collapse with expiration, increasing resistance. And so in any of these situations, we need of more forceful inspirations. The more forceful our inspirations can be, the more energy they are going to require. And so we are going to see somewhere between 4- and 6-fold need in energy. And so these patients that are dealing with these conditions can become exhausted just because their total body expenditure goes from 5% to 25%. Now let's talk about compliance. This term describes the ease in which the lungs and the chest wall is expanding, and it's determined by surface tension and the elasticity of our chest and the lungs. The easier the lungs expand, the greater compliance that we have. So that brings us to restrictive pulmonary disorders. Make sure all my images show up here. So our vital capacity is reduced when we have a restrictive disorder like this because the lungs have lost their elasticity. So we mentioned pulmonary fibrosis, where we see some of the fibrous connective tissue building up in the lungs, and it could be due to inhaled particles such as sand, coal dust, asbestos, and fiberglass, and essentially cause the lungs to build up scar tissue. So now our lungs cannot inflate properly, and it can also lead to cancer, especially when we are talking about these foreign substances being within the lungs. And the FVC, which, if you remember, is the amount of air that can be forcibly exhaled after taking the deepest breath possible, is much lower than in comparison to our normal patients. So here in the yellow, we see the volume exhaled much lower, and the red is representing our ability in our normal lungs. So usually we see this somewhere between 75 and 69%. Now, a different type of pulmonary disorder is obstructive. The air is not flowing freely in the airways, and we can classify chronic bronchitis, emphysema, and asthma as chronic obstructive pulmonary diseases, or COPD, as you often hear it referred to. And this is because they tend to reoccur. Now, in these patients, we typically see the FEV1 FVC ratio is lower, less than 69% in people with the restrictive disease. So much lower here in the blue. And in this condition, we tend to see these patients have slow exhalation as well as reduced FVC like we see here. Now let's highlight each of those diseases that we talked about, starting with chronic bronchitis. This is when the airways become inflamed and filled with mucus. The bronchi start to go through degenerative changes, including, we know that lining the respiratory mucosa is that pseudostratified columnar ciliated epithelium. And so we start to lose some of that cilia, and we know that that is useful to move some of these substances, moving the mucus. And if we are not able to move it, then this mucus kind of stays in place. We've also talked about how smoking is a frequent cause of that cilia being diminished as well, and so it could lead to chronic bronchitis. There are some pollutants that can also cause this disease to continue to be chronic. And then we have emphysema. This is chronic and unfortunately incurable. And as we have our normal alveoli here, notice that we've got almost like a sack of grapes here, so lots of surface area. But when someone has emphysema, we start to lose that alveolar structure of those little grape-like sacs, and instead have these larger sacs, which reduces the surface area, meaning we're going to reduce the area that we have for gas exchange. So less oxygen is reaching the heart and the brain. Most often, smoking is going to cause this condition, and will have that elastic recoil of the lungs reduced as well. So not only are we narrowing our airways and reducing gas exchange, but the driving force behind expiration is also reduced, because we need that elastic recoil, that rubber band that pulls the lungs back down and allows it to inflate. So the lack of that oxygen to the brain can make a person feel depressed, sluggish, and irritable. And we know that when it's severe, we can treat it with a lung transplantation or something known as an LVRS, a lung volume reduction surgery. A third of the most diseased lung tissue is removed in this case, which enables the remaining tissue to function much better because there's less of a strain on that lung. And lastly, we have asthma. The symptoms of this is going to be wheezing, breathlessness, and sometimes a cough. and sometimes an expurgation of mucus, meaning that the patient is coughing up or spitting out material from the respiratory tract, which could be the mucus itself, or if it's coming out from the mouth, we are going to call that sputum once it is out. And this usually is going to occur when we're exposed to an irritant such as pollen or tobacco smoke, and the smooth muscles within our bronchi or bronchioles are going to contract and relax, so causing a spasm to take place. Unfortunately, asthma is not curable, but it is treatable with special inhalers such as albuterol. And the last thing we're going to talk about in this section is dead space, known as a VQ mismatch. So when we have pulmonary circulation, the pressure is going to be really low there compared to our systemic circulation. Now, we haven't really talked about our circulatory system just yet, so let me explain what that is. Pulmonary circulation is going to be when we are having blood from the heart go to the lungs and then back to the heart. Whereas systemic circulation is when we have that oxygenated blood in our heart being sent to pretty much everywhere in our body, all of the systems of our body, and then coming back to the heart. So we'll, of course, go into more detail on this in our next chapter. So the reason the pressure is low in pulmonary circulation is because we're really just pumping blood out to one organ, the lungs. Whereas with systemic circulation, we need more pressure to push that blood out to all of the different systems of our body. So our body goes through recruitment, which is the process of opening airways that normally remain closed when cardiac output increases. So think about when we are exercising, we are going to increase cardiac output. So now our lungs know we need to be able to bring in more oxygen, and those airways are going to open up. So as that cardiac output increases, our capillaries are going to be perfused, meaning it's filling with blood, and then we're going to allow that oxygen to move into the capillary bloodstream, and we give off the carbon dioxide, and then we breathe that out. So when we have ventilation perfusion mismatch, V is for ventilation, Q is for perfusion, we have the amount of air from our ventilation and the amount of blood or perfusion in our lungs not matching up. So there's two ways in which this happens. First, we have our anatomical dead space, and think anatomical, more of our structure, more of the ventilation process taking place, where it is our conducting zone. We're just bringing that air in and out of a space. There's no gas exchange taking place. So there's areas where the air might be, but again, we're not having gas exchange taking place. Whereas the physiologic dead space is our normal anatomic dead space plus any loss of alveoli, or it may be a loss of the capillary here so that we are not able to do gas exchange. So typically it's due to damage of our alveoli or changes in what we call the respiratory membrane. And let me go back and just describe what I mean by that respiratory membrane. Here we go. So we refer to the respiratory membrane as this over here. So you could see it labeled down here, and it's made up of 4 different layers. I won't go through the layers. We'll save that for an A&P course, but essentially this membrane in which the gas is able to diffuse back and forth. So between the wall of our capillary, there's an interstitial space, and then the wall of our alveolus. So of course this damage to the alveoli could be due to some disorders that decrease the number of alveoli. This could be pneumonia due to that mucus or fluid building up within the alveoli. And we also talked about emphysema and how we decrease surface area of the alveoli. So a physiological shunt can develop if there's an infection or edema in the lung that obstructs an area, and we'll see decreased ventilation but not affect perfusion. So as a result, we'll see a functional impairment of the lung or arteries, and our lung can start to compensate for these mismatches that take place in ventilation and perfusion. If ventilation is greater than perfusion, then our arteries can dilate or widen, and the bronchioles constrict. And so this increase now in perfusion reduces ventilation, and we have more of a match. If ventilation is less than perfusion, then our arterioles are going to vasoconstrict, and our bronchioles can dilate to correct the imbalance. Now, of course, our lungs can only compensate for so long, and as a disease progresses, the mismatch is still going to take place.